Okay, beautiful. So welcome everyone. This is Grief and Loss in Veterinary Medicine with Dave Shuey. This is with Black DVM Network. Black DVM Network is a safe space and an online platform for Black veterinary professionals. So that includes veterinarians, technicians, assistants, students, and anyone else who is in the business of caring for animals. We have a member platform, and so that is available specifically for Black veterinary professionals, but still open to anyone that would like to be a part of it. Before we get started on this webinar, I do want to mention that Black History Month is right around the corner. And so I would like to share with you all our list of events. If you guys can see this, this is the quick flyer that we have. So we'll be doing a kickoff about a week from today for Black History Month with our annual trivia game. And then we'll be doing IG Lives with the Veterinary Emergency Group on the art of veterinary medicine. We will be in Las Vegas for the Western Veterinary Conference. And so if you're looking to connect, we will be at Mandalay Bay hosting a happy hour that's open and free to everyone with Pride VMC. And then later on in the month, we have our summit, Refocus, Refresh, and Recalibrate. So we'll be talking about how to get back into the new year, set some goals, and prepare yourself for the rest of 2024. And in 2024, we are mainly talking about practice ownership and entrepreneurship. So if you're interested in that, you can stick with us all year long. And then our last event of the month is going to be about building in underserved communities. And this is with Companion and Animals for Reform and Equity. And we'll be talking about some of the myths that people might have about how to build and maintain practices in veterinary deserts. So I just wanted to make sure that you all were aware of those things. I also want to introduce you guys to IndeVets if you're not familiar. IndeVets is an annual partner with Black DVM Network, and we are so grateful to have them. They have created a whole new way to practice that puts veterinarians first. And so they take what makes associate work reliable and combine that with what makes relief work flexible. And they handle like payroll, so they're making sure that you get a paycheck, full benefits, and total control of your schedule with a team behind you that's dedicated to your happiness and growth every step of the way. And so with that, Dave Shuey is with IndeVets, and he is a licensed master social worker, I'm sorry, author, pianist, and equestrian. He creates and provides wellness education and support for the IndeVets relief veterinarian community, working to increase veterinarians' professional health and fulfillment and longevity in the profession. And he also maintains a small clientele and private psychotherapy practice. So Dave Shuey will be talking to us about grief and loss from human and animal perspectives. Just a couple of things for this presentation. We ask that you have your video off during the presentation since it'll be recorded. That way there's not too much distraction going on and we can keep the bandwidth down. But then afterwards, if you have questions, you can feel free to come off of mute and to turn your video on to ask Dave. If you have questions during the presentation, you can throw them in the chat and I will find a good stopping point for him and try to ask those during the presentation. This webinar does come with one CE credit, race approved CE credit. And so I will need your email addresses. Most of you probably, I have your email addresses from signing up on the website, but if for some reason you used a direct link, I'll definitely need that. You can feel free to put your email address in the chat directly to me if you don't want anyone else to have it, or just in the general chat, and we'll make sure that that gets recorded. And then Dr. Cantor, she was on a few minutes ago, and she mentioned how she'll be asking you for your license number in an email in order for you to get your CE certificate. Amazing. I think that's everything. Did I miss anything, Dave?
I think that's enough to go on for sure. So thank you for that introduction, and welcome to everyone here. A couple of very dear friends from our IndeVets family, and I look forward to meeting new friends here tonight as we talk. So I'm going to get my own personal vulnerability out of the way and talk myself through sharing this screen. And Now I gotta put this thing here. Then I gotta tell it to play from the start. So let's see. There we go. I even know how to do that now. Okay, so does everyone see that in full screen? Sam, Sage, can I get a what?
You got it.
Thank you. I have to do that at Superstition. So anyway, welcome to Grief and Loss from the Human and Animal Perspectives. As was said before, I'm the social worker at IndeVets, creating all things wellness in terms of peer support and education and leadership development and training and hospital outreach and anything you could imagine in sort of an independent veterinary environment. So this is my niche, and this is the home where I always want to stay doing this work. How I got here was late in my musical career, or what ended up being late in my musical career. I got my first horses. This was in Colorado back around 2006 or 7 or so, and realized that I needed to make a shift in my life to have the horses and the music. I wasn't willing to give up either of those. So went to the Bell Ray Institute of Animal Technology in Denver. It's the first veterinary technician program accredited that ever was, and started off in small animal dentistry. Thought that's what I wanted to do. And then we moved to Georgia where we could have our horses on our own place. And eventually I transitioned into a role as an anesthesia technician at the University of Georgia Veterinary Teaching Hospital. From there, having seen everything that could possibly go spectacularly wrong in the different ways that we care not only for the animals and the people, especially in a university teaching setting, I found animal hospice and palliative care as a new kind of specialty that's been emerging over the past decade and a half or so. Got certified in that and began back in a private practice setting to work with not only the people who were losing their pets to make that transition as dignified and meaningful as it could be, but also with an eye toward the mental health of the practitioners, those of us that do multiple euthanasias, especially with our in-home people. And that's one of the ironies that we brush up against, is that what is usually the most emotionally taxing thing to do and the most morally distressing thing to do in a profession where one of our bioethical pillars is to do no harm, we're also responsible for relieving suffering, as we tell ourselves, through the deliberate taking of life. And yet, with our friends in the in-home euthanasia community, they see that as an honor and actually draw meaning from leaning even further into that part of practice. And so I'm hoping to explore tonight kind of how we all experience loss and grief, and how we mourn, and how we express how we feel based on what we're exposed to in our lives. And so we start then with a few definitions. And I try to really simplify this for people because unfortunately the grief care industry is very, very loaded with a lot of terminology and a lot of jargon and a lot of labels and a lot of diagnoses and a lot of, let's face it, sales pitches for people's different programs to make sure that we get sort of almost dependent on this kind of care, that we don't have within us the wherewithal to lean into our own suffering, move toward our own suffering in order to heal, and doing that in the context of a trusted social environment. So when we talk about bereavement, that's the feeling of literally being torn apart, disoriented by loss or the threat of loss. That takes the place of terms like anticipatory grief or ambiguous loss. It doesn't matter really what the circumstances are, but the feeling that we are literally being torn apart because we are losing something in our lives. In our cases, it's our patients. We actually go through the loss of a patient when we perform euthanasia, or even we hear about it, a patient we may have been caring for a long time, sometimes since birth. And we also, of course, lose family members, we lose colleagues, we lose jobs, we lose locations, we lose roles. And so that feeling of disorientation and that dread of everything suddenly becoming unknown, that is bereavement. And so that expresses itself biologically as grief. And I confine it to this biological sort of deal, as you'll see later, because everyone experiences grief in different emotional ways, and those ways are determined by our backgrounds, what we had for lunch that day, what we were thinking about in the previous hours and minutes, and what our neurotransmitters are doing and everything like that. But what it does share, that bereavement produces the same exact stress response as if a lion is chasing us. So the adrenals squeeze, the amygdala fires, and our appetite goes away, our spit dries up in our mouth and eyes dry, and we get very, very focused on this trauma that is happening to us and just trying to survive. And so grief is the internal biological response to loss. And there's a lot of misconceptions about that we'll get into, about how do we know that we're doing well with our grief. And a lot of times it is the inverse of what we might normally think of. And that's what brings us to mourning. Mourning is the outward expression of that internal biological response that's going on. So mourning would be funerals, wailing, crying, screaming, collapsing into a puddle if we have to, expressing all of the normal range of emotions that are associated with grief, all the way from that crippling fear of the unknown in that acute bereavement to the extreme sadness, the disbelief, the numbness, the shock, all the way over into anger, resentment, rage, betrayal, unfinished business, all of those things. That sounds like bereavement. That sounds like being torn apart. And so those feelings are all completely under that umbrella. Even some unexpected feelings like relief. I've seen clients that have been struggling with a decision to euthanize, and a question that I would ask them a lot is, well, what if you have made the decision, we've done the euthanasia, and it's been 10 minutes? What do you feel? And the person's shoulders will relax, their facial features will soften when they've given themselves a chance to actually engage with, up there in the bereavement definition, the threat of loss, and actually stare into the heart of it. They realize that the other side is going to have feelings that they did not expect to have. And so even in the simplest terms, there is worlds of meaning and worlds of emotion that we can engage with and help people with. And so we'll start with a story. I'm going to tell stories throughout this whole thing. I'm going to spend a lot of time on these slides because I don't have a lot of them, and I want us to just relax and gaze at them and maybe listen to ourselves a little bit as you listen to me. So I learned about the true biological nature of grief as a mental health professional out of social work school. I spent a couple, 3 years in a state contracted mental health facility for underinsured, uninsured, homeless, substance abuse, all of this stuff, post-suicidal, actively suicidal people with severe and persistent mental illness. And so during that time, we're going to get to one of these ideas that loss is going to be inevitable no matter what. And part of coming to terms with grief and loss from the human and animal perspective is how we engage with that inevitability. And so I experienced that inevitability on May 13th of 2022, where 2 hours after a session with me, one of my clients died by a fatal overdose. It is not clear whether it was intentional or not. But that being said, I could no longer drive to work without chest pain. Doing a progress note, a simple progress note that used to take me 5 to 10 minutes and I could get done early and go home, was now excruciating and was almost physically impossible for me to type the narrative to whatever the session was, because I just could not tell whatever the story was again that I had just shown up for, in the same week after this happened. And so luckily we had a great support system and people came in, and I got to, really talk to my clinical supervisors and my managers and my colleagues and stuff. But really what helped me persist was the Ativan. It was the calming down the biological processes that were skewing my thoughts and feelings in those areas that really allowed me to bring forward the techniques that I was trained in and would help my clients. I mean, I ran a weekly grief and loss group at this facility for over a year and a half, and it was my baby. And so even still, biology really took over and dominated the course of my recovery from that. And so as we get into some of these misconceptions of grief, usually misconceptions of mourning, is that we ever actually get over it, because we don't. Grief is a permanent change in our lives because of the loss being permanent itself. And so part of that mourning journey is realizing that we're in a wilderness, realizing that there is no path, realizing that there can be little markers here and there that we can find along the way. And there's also this task of developing a new identity in how we see the world and how we see our practice. So maybe part of seeing how we see our practice is going to be a little bit of a story that I found in a DVM 360 article from, I believe it was 2009 or so, by Ken Marcella. And so I quote from there: "Ben and Doc had been together for a long time. They were born in the same area, lived together, and actually worked side by side for many years. They noticed they retired to the same place and had been spending their elderly days quietly. But when Doc became ill and quickly died, Ben was devastated. He stopped eating, didn't want to move around much, or to do any of the things that had occupied his previous days. He wouldn't interact with anyone around him, and he became severely withdrawn. Without his friend to do things with, he became inactive and started losing weight and muscle condition. His arthritis, which had been doing well, became worse. Not eating enough began to weaken his energy and his immune system. He started to become anemic and dehydrated and showed all the signs of physical and psychological depression. This is not an unusual scenario, and the loss of a close friend or a loved one can be seriously stressing to people, especially the elderly. But Ben and Doc are horses." And so as we move into talking about what is this experience that we share with the animals in terms of loss, and how does that show up, and how do we think about lifting our care with this knowledge and with these perspectives. The first is that loss is inevitable. And we as humans have kind of a special claim to that, because we can invent words like anticipatory for the grief, because we are self-reflective enough and we have enough neurons up in our heads to reflect on the fact of a terminal diagnosis, and to be able to imagine ourselves without the person in our lives, or even an emergency situation, to know that it is hopeless and to know that eventually death will come. Animals may share that to a certain extent, but what we do know as We get more and more evidence through fMRI and through electrical stimulation of the brain and through EEG studies. That's what a certain a guy named Jaak Panksepp, who's an affective neuroscientist at Bowling Green State University, and he's come out with a lot of books about this. And he studied the limbic system of a bunch of animal species, including humans, and has mapped out these different circuits that go on in the limbic system. And so it turns out that grief, that biological response to loss, shares the same circuit pathway as panic. And what is grief but panic over that sudden change that is brought by loss? You think about what, anyone, a baby bird or a little puppy or a little baby foal would do when mom is out of sight, or a human baby. They haven't learned object permanence yet. And so what happens when mom leaves the room? They lose it. They are completely shut down and devastated, and usually vocalizing very loudly. And what that is doing, I've heard it termed, is they're calling the loved one home. And that's what part of the emotional response and the emotional outgrowths of the biological grief response is doing. And that's what we're doing when we're mourning. We are trying to, in some way, call the loved one back home into our lives and align ourselves with that reality that death may end a life, but it doesn't end a relationship. That's a common phrase that is going on there. And so a couple of concepts with that. And I want to spend a fair bit of time with this idea of normal grief. And I put here, grief is normal until it isn't. And I suppose I should tell you what I do not mean by grief not being normal, or how do we classify normality and abnormality in grief. Normality in grief has nothing to do with the intensity. It has nothing to do with the duration, and it almost has nothing to do with the actual clinical signs that a person might show. Grief is not normal when it is not accepted by the person's social group, by the person's culture. When grief cannot be shared, that's when it turns inward and becomes depression, becomes panic disorder, becomes PTSD, because if there is no outlet for the grief, that is what turns it into something that is not normal because it is not accepted. And so we can safely ignore a lot of what's been said in recent editions of the Diagnostic and Statistical Manual of Mental Disorders. There's actually something called prolonged and persistent bereavement disorder. Now, that is such a lot of syllables to just describe what normal grief is, because it is occurring along that ancient part of the brain compared to our self-reflective frontal cortex. It is going to behave in ways that very much mimic what we might see as animals misunderstanding what's going on. As we're going to see, animals understand a lot more about loss than we think. So grief is normal until it isn't, and it isn't normal when it's not accepted by someone's trusted social group, or by someone's family, or by someone's coworkers, by others. And for that reason, mourning is individual and unique until it shouldn't be. And so those statements go together, don't they? If, again, we don't have the outlets, we don't have the safety to tell the truth about how we're feeling. I always think of like the single most useless phrase to say to someone who is obviously in mourning is, "How are you?" That recalls a funny story by the journalist Christopher Hitchens, who had terminal esophageal cancer, and he would go in for his chemo, and they would always ask at the clinic, "Oh, good morning, Mr. Hitchens, how are you today?" And his only response was, "Well," and he's called Oxford British person, which I can't do the accent. He says, "Well, I seem to have cancer today." And that's how safe we should feel, and to tell that kind of truth. And the great thing is that that is all that needs to be tasked of the person that is there with them. We don't need to ask them how we are. All we need to do is be there. I'll get much more elaborate with that later on. One last little story about grief being normal is from a couple of standpoints. From the human standpoint, I had a client who had a little Yorkie. This client was a nurse practitioner and very, very knowledgeable about medicine, had some very specific goals of care, and knew, where the lines in the sand were as far as her managing this dog's disease. And it was a Yorkie, so you might do a lottery and throw a dart, and if your dart is most likely to land on tracheal collapse, that's exactly what the dog had. And she managed the dog for many, many months and was happy and went everywhere with her in her purse and all of that stuff. But here's where we trip up over this normal thing, is when it was basically a planned euthanasia. We've tried to say in euthanasia practice that we are trying to spare the animal from the worst that the disease has in store, and that's how we turn it into an ethical, honorable practice as much as we can. So the euthanasia went fine, but where the rest of the staff tripped up was where she wanted to take the dog's body home and keep it in a chest freezer until she was ready to bring it back for cremation. She kept this dog at home for 2 weeks, and every day would go to the freezer, pick the dog up and hold it, put it back. And I was one of the ones in that room, and I said, well, sure, of course you can do that. It's not a big deal. And do you mind telling me kind of why that's important to you? And she said, well, the last dog that she had euthanized was taken from her arms while it was still warm. And so that is where somebody tripped up over what is normal and what shouldn't be, and wasn't really listening to the actual needs of the client. And so at the end of 2 weeks, she brought the dog's body back and thanked us she said, for putting up with her behavior. And we said, no, we realize now that it is completely normal, and this person actually came through that process in much better shape than if there had been any kind of discussion or conflict or misunderstanding around what her actual needs of mourning were in that time. And we see that in animals. I mean, who remembers the stories? And there's several stories about orcas that, whether the calf dies after birth or is stillborn, they will carry that calf for a long time. There was the story of the orca that carried her calf over 3,000 miles for about 30 days or so, at least a month, before she felt like she could let the body go. And that is exactly what we are trying to do. We are trying to make sense of the fact that this loss has happened, and make physical sense of it, make emotional sense of it. And I picked the orcas because, again, in the biological sphere of things, the fMRI studies that have been done on them show that in their limbic system, they have so much more surface area in what's called the paralimbic cleft. And that means that there are so many more dendritic pathways and neural connections going on up there, that they could very well have emotions that they reflect on that we don't even have words for, or ideas for, or even any frame of reference for. And so if they are experiencing emotional worlds that we cannot imagine, and this is what brings meaning to how they process loss in their lives. It says right here in Marcella's article, 2004, I was wrong on the date, but Dr. Crowell Davis was a animal behaviorist, and she taught at the University of Georgia where I worked. And she says, when animals are recorded showing the same patterns of brain activity and the same brain chemical changes that respond to a particular human emotion or mood state, it would not be logical of us to assume that they are not experiencing similar feelings. And so from there, we're going to move on to how we as social units help each other deal with grief and understand grief and mourning. And we're also going to see how animals do it in different ways. And I just got to checking the, oh, thank you, Tiara, for the notes on the presentation. Knew I'd missed something there, so appreciate that. And just letting you know, I'm checking the chat too, so I'm not ignoring people, hopefully. But another little story then about people who are witnessing the loss and people who are witnessing the bereaved, or who actually may be in the role of the bereaved person. And hopefully so far we've covered a lot of different permutations of that. This comes from two different parts. One is the old HBO series Deadwood, which was about a town of the same name in the Black Hills of South Dakota right after the Civil War. There's a scene in the fifth episode of the first season where the character Reverend Smith is giving the eulogy at Wild Bill Hickok's funeral. And so he says, Mr. Hickok will lie beside two brothers. One he likely killed, the other he killed for certain, and he's been killed now in turn. So much blood. And on the battlefields of the Brothers' War, I saw more blood than this, and asked then after the purpose, and did not know, and don't know the purpose now, but know now to testify that, not knowing, I believe. And so what he's showing us is this: when we're experiencing loss, we're back to what I said about the unknown, is that the unknown is right in our face, and our only option is to step into it. And how the heck do we do that? And so the writer of Deadwood, in his memoir, comments on that scene. He says, what we see in the second half of that season is the minister getting sicker and sicker with what the doc realizes must be a brain tumor. The minister is losing his mind. There is nothing to be done. The disease must simply progress. The reverend has to live through the changes. Everyone around him has to live into their inability to do anything to change the outcome. And so perhaps part of a larger paradigm shift we can think about when we're facing grief and loss, both in our own practice and in our lives and in the lives of our animals and in our clients, the harder we hold on to outcome, the worse we end up feeling in the end. That's why hospice and palliative care came into existence, is because of that very fact that we're no longer treating for a certain outcome goal. We are treating to uphold certain principles, those being quality of life, the pleasure of eating, physical comfort, the ability to express normal behavior, which is said by the ASPCA in all kinds of different places. And so we start thinking along many different lines. And so what I'm going to show you next is, I guess I could call it the case study part of the evening. And this concerns two losses that we experienced on our farm here in Georgia. And the first one was, we've always had mares. And so this mare was named Carrot Jane. She's a wonderful medicine hat paint horse that I was starting some dressage on in 2018. And she was running in the pasture, having a ball, and tripped about 12 feet in front of me and landed on her right side and shattered her humerus. I heard it go and saw the way she got up and how she was breathing, and immediately called the vet. I didn't even want to do radiographs, but we managed to, because I had gotten maybe 8 grams of bute into her, just so that she could bear to stand there and not start panicking and needing to move around and causing more damage. So we stood there and waited for the vet, and we confirmed yes. And so, being a hospice tech at the time, having gone through that training, I said to my vet, do you have ketamine on your truck? And she said, oh, you want to anesthetize her to lay her down? And I said, yes, because in equine euthanasia, I will always argue for anesthetizing them to achieve the laydown if they are not already recumbent. Because a brain dead horse lying down is orders of magnitude more dangerous than an unconscious horse laying down. And so with a broken leg, we gave her the full vial of ketamine, 5 mg per kg, plus a vial of Valium, just for the muscle relaxation and the anxiolysis and all of that. And I was able to hold her head as she sank onto her hindquarters, and I guided her gently into lateral recumbency. And the euthanasia injection ended up being an afterthought, being already asleep and having administered the euthanasia injection slowly enough, she was able to pass perfectly peacefully with no agonal breathing and with no involuntary stretching. I don't know how to say that term. And we had the presence of mind to allow the other horses to see everything. They were in a separate pen because there was a truck out there, and we didn't, want them, if they happened to need to move around, we just wanted to keep everything safe for the veterinarian. But once the truck left, we let them out and just allowed them to do whatever they felt like they needed to do. And we filmed it. And so this is what they did. There's 2 videos here, and I'll play them a couple of times. That little snort you hear is my little Mustang. She hasn't come quite out yet. But notice how little panic there is. How many of us have had owners worry and ask us, should the other dogs be present? Should the other pets be present? Should the children be present? And a lot of times we're wanting to protect them from things that might traumatize them. But as I hope we've seen, it's actually far safer to allow them to approach the unknown, to approach the pain, and to move away from it, and to be able to share how they're feeling and be included in what's going on. So one more time, just look how they fan out, they give each other space, and they glance at each other with their ears. And then we can see when Shelby comes out to join them. And so they did that for around 15 minutes at first. And then they all went up the hill and grazed a bit, and then came back down and repeated this for about 3 or 4 times until it started getting dark and the funeral truck came to transport her body, had her cremated. We have a whole body equine cremation facility here in North Georgia, and it is not cheap, but in our state, and this was the first horse that we had ever lost on the farm, we decided to do it that way. And they visited the spot for about 3 weeks. Later on, they would pause there before coming in for their breakfast and dinner and before going out to the pasture. And we just observed as they would do it, but they kept hanging with each other and just having that togetherness. Again, the place for the outlet, the place for having some sort of reference that we are not allowing the very normal grief to turn inward and become something that should not be normal. And next is the second loss. You notice the black and white paint horse, that's Lily. And she was not a euthanasia, she was a natural death. We had been managing a chronic respiratory issue with running up and down the list of everything that was on the culture and sensitivity in terms of antibiotics. And I was giving all the stuff to her. And I remember giving her Banamine before she went out that night. This was in October of 2018. She had never stopped eating. She had never She was always a little bit tachypnic, but never febrile, and otherwise engaging normally with the rest of the horses. She would go seek out shade, became kind of temperature sensitive, but we had made the decision to limit the intensiveness of our care to the farm environment because the stress of the hospital. I've just seen too many horses with pneumonia come in, and half of them leave the hospital and half of them don't, in my experience. And it's the stress on that particular system, and you're talking quality of life. When they can't breathe, nothing else matters. We know that from human medicine. But notice that even with now the truck in the pasture, this is how the funeral truck does it. He used the winch to turn her body over onto the sled, and now he's covering everything up. But he allowed, and we allowed, her best friends to come and sniff, and just to go through that process that they were used to and had confidence that they would be able to do when this happened. And so toward the end, this is how now she's all wrapped up and covered and on the truck and headed for the crematory. And Julie, the horse that you saw sniffing her nose earlier, I think she was about 29 or 30 at this point, and they were best friends. And you can see that there are things going on in that limbic system of hers where she is processing and going through and informing herself about what's going on. And later on would do all the same things. She would visit the spot. She would, just take little extra glances around and things. And so what I'm hoping we learn is that there are times in for lack of a better word, process. It's really not a process. It's a cycle of grief, loss, bereavement, and mourning, that there will come times when we think we're crazy, when it's been 3 years, and our brain will give us a little just glimpse out of the corner of our eye. Wow, there's that cat that, I euthanized 7 years ago, and I just saw him out of the corner of my eye. I see our horses out of the corner of my eye all the time. And we think we're going crazy. And we see certain behavior in animals, like I talked about with Ben and Doc, how it was classic PTSD and the depressive modality. And that is what someone who doesn't have those outlets and who doesn't have that trusted social network will start thinking that they're crazy. And so Dr. Marcello reminds us that it's likely that we will be finding out that with many of the behaviors and emotional states that we currently only assign to ourselves are also found in horses, by extension, whales, birds, all of the other mammals. It might actually be far crazier to assume that these horses do not feel many of the same things that we do. And so seeing what we share with our animal companions in all the different ways we treat them, we have them in our lives, and how we care for their families and how we care for each other, I hope I've given you a little bit of a picture of just how awe-inspiring this part of being alive is, and that we're able to bear witness to it in our work with all of its different hazards. But as long as we've got each other, I think we'll probably be all right. And so I would like us to get with each other for how much ever time we have for questions or any dialogue or anything that has come up for anyone, if anyone wants to say anything. Or I always love just sitting in silence for a minute or two as well. So I will stop sharing and see what people think.
Thank you for all of that. I really enjoyed that. And there were a few things that came up for me, but I do want to give a little bit of space in case anyone else has questions or comments first. So one of the things that I kind of came into this webinar wondering about were experiences with euthanasia. I'm a veterinarian, so that's my role in the euthanasia process. And one of the questions that came up for me, especially like coming into this webinar, is around clients or pet parents not being present for euthanasias, and what you think about that, whether that's a rule from the hospital or that's a choice of the clients.
Wonderful question. And from that question, I can definitely infer that people have a lot of feelings about that from both sides. Like, I've read a lot of things where, doctors will express their own, I don't know what emotional term to put with it, but because we are the ones performing the euthanasia and we are there in the last moments with the pet, it's real easy to have questions about why the owners would decide to do that. For me, it is always the owner's choice. And I think what makes it slightly more palatable, I think, or at least just a little more manageable, is as a hospice tech, I would always have the euthanasia conversations at the time of diagnosis, at day one. I would say, how do you want the last day to look? Do you want to have it at home? Who will be, and answer those questions, who will be present at the time? Because to get them imagining that while things are relatively good is much, much easier than saying, do you want to be here when we do this? And you've got the syringe, because that's in a panic state, and no one can make a decision that they are confident that they may or may not regret in that state. So for me, it's the timing of that conversation. The earlier we have the euthanasia conversations, the earlier in the process, as early as we can, and make it about, again, not the outcome, but the principle here being patient/client autonomy. So we're caring for, it's whatever is going to service the human animal bond. And some people do not want their pets to see them in the state that they're afraid they're going to be in.
Mm-hmm.
Whether that's backed up by any kind of evidence or not is irrelevant. It's, are they going to derive more meaning and be able to process it better from not being present? So it's those different roads. I hope that answered it a little bit.
Yeah, I didn't know if you had, because like you kind of mentioned, you're like, there's not much evidence around it. I didn't know if you had any like any evidence or data supporting like clients being present or not. As an emergency, as a veterinarian who spent most of my time now in emergency, I get a mix, right? And usually there's not much prep for the time, unless people come in knowing that that's what they would want to do. When they walked into the emergency room.
Yeah.
But I have heard of a couple of clinics that say, well, we just don't allow clients to be present. It's much easier for us. And
Right.
clients love it. They don't push back on it. And so I kind of wonder, because I think it should be up to the person, whether they want to be present or not. And so I was just wondering what your perspective on.
Yeah, it's all in what you're comfortable with. And in the references, I believe I did put a few things about some recent studies, like from last couple of years, by my friend Kathy Cooney, who does Companion Animal Euthanasia Training Academy, and some people up at Colorado State, about owners' expectations around euthanasia. And of course, these are owners that are willing to participate in that study and ask those kind of questions, and so they'll get themes from there. And so it's still very qualitative, which is fine. But I think it's exactly right. When for a place to not allow owners to be present, that just means that's their comfort level.
Mhm.
And it's actually, better, because the worst thing in the world is to not be able to find a vein on the kidney failure cat that weighs 4 pounds and not have intrarenal injections and dosages in your toolbox and be able to say, because that's how I would, every cat that I euthanized as a tech under supervision and things, I would never go for a vein. I would always, if I felt a kidney, put the blanket over, they never see the syringe. And the objective data there is that if you feel the kidney swell as you inject, they will pass within 2 minutes. So there's lots of that. And so it's a spectrum of that comfort level. And it can be from a very technical perspective, which is totally legitimate, because we still need to feel like good enough to go back and do it the next day. And, we put ourselves through a lot. I wanted to look too at, Kelly put a wonderful thing here. I think it's important that we recognize, yes, grief is different for everyone. And a surprising thing is how, they can appear aloof, real, just expressionless almost. Um, and of course, we don't understand that when we're first in practice, and the degree to which we don't understand it depends on what we've been exposed to, and obviously, and all that. But then, it can be and is usually a coping mechanism. My thoughts on that are, you are absolutely right. That is a species of coping mechanism called disassociation. And where we hear about that is, of course, in a pathological framework. And I'm sorry, but depersonalization is nothing more than your brain's way of protecting you from feeling too much at once. It's the same reason we feel numbness, we feel disbelief, what Kubler-Ross calls denial. And even that's a little too moralistic, and it's not biological enough for me. It's just, this is a brain, this is a body protecting itself from the implications of what's happening. And so, absolutely. When my father died, he was 84 and my mom was 80, and it was natural causes and very expected. But the nurses at the hospital all really looked at her funny, because she's like, I just don't feel like collapsing down into a puddle. He's at peace and he's happy now. I mean, the look on his face is like he just hit the perfect golf shot, and you know, but that's her upbringing and background, because growing up in the Depression, she lost everyone by the time she was 16. So that context always plays into it. But yes, Kelly, absolutely right. Disassociation can be our friend. Yeah. And you don't study this in vet school, you bet. You absolutely do. And so hopefully we change that through bringing these concepts from end of life care, and this the companion stuff with studying grief and loss. So that's really cool, and hopefully we'll make some of those changes. But I will not leave here until I don't want anybody to be able to say that they had a question that I didn't answer. So anyone can pipe up with anything.
So while everyone else is maybe thinking about some things, I also kind of wanted to see what your perspective was on Because you mentioned about having that euthanasia talk like at the time of diagnosis or just having it as early as possible.
Mhm.
And again, from an emergency perspective, there are a lot of times that people come in and they were not expecting to lose their pet that day.
Mm.
Do you have, and I mean, like, right, like the most horrible kinds of cases, like the 2-year-old dog that got hit by a car, or the 6-year-old dog that big dog, little dog fight, those kinds of things, right? Or someone, rodenticide. Working in New York City, I saw a lot of rodenticide, and people didn't realize that that was toxic to their pets. He pooped out green stuff 2 days ago. I thought he was going to be fine, right? And now he's bleeding out. So, do you have any recommendations on navigating those sort of like, unexpected losses or unexpected death conversations?
Yeah, the more unexpected it is, the more acute it's going to feel, obviously. I mean, it's mirrored, right? In an ER situation, there's nothing but high acuity. And so it would stand to reason that that is. I think it's really down to, because within our sphere of logistics, I mean, if it's possible to get the animal like decently anesthetized, like I think with horse stuff, it's like, can we just get them anesthetized, get the Valium, get the ketamine, and just get them asleep, just get them sleeping, and we have 20 minutes to, do our process. And what that process is, I think it comes down to just learning some where you can. And in the references, there's going to be a lot of that too in the written proceedings. But certain communication techniques, like there's one really good one called chunk and check, where you can just have, yes, you have to deliver this horrible news, but you do it in small chunks. You say like, okay, here is the radiograph of the pelvis, and here's why it can't be fixed, and here's why, this is a catastrophic injury. What's your understanding of that?
Mhm.
And then here's why it's, not fixable, because one, two, no more than three things. You don't have to go through the litany of like everything about the sequelae of those things. It's just moving together, companioning with the client and partnering with the client through their understanding. And then the decision is something that you don't hopefully need to feel like you're pushing for. Because when we know the right thing to do and we're all the way up here in the thing, but the owner's all the way back here, there's no best practice going to happen there. So
Right.
somehow we have to bring it to, yeah, we have to be that authoritative, like this is what's going on. And ethically, I mean, euthanasia is the only humane option. Yeah, we got that. But we got this client that we need to somehow partner with and win the trust of, to walk through each thing. And so it's dividing up the message and having it be a dialogue. And the other symbol is of a frisbee that you throw back and forth, not a shot put that you just plunk right in the middle of everything.
Yeah. That makes sense. I'm thinking of like some cases, and I feel like people usually just need a lot of time, and sometimes the animal doesn't have even that, couple of hours for people to
Mm,
decide.
yeah.
Um, and that makes it really, really tough. So,
I am going to send, if so, that sparks a thing. I had not planned to do it, but I don't know if I have the ability to share documents in the chat or not. So
hopefully you can. I was able to put something in the chat.
And
I
if Dave, if
put
there's anything you want to email out after, I can always email stuff out with the certificates too.
okay, cool. Because there's an organization called Ariadne Labs, which does a lot of human hospice work and stuff like that. And they have something called the Serious Illness Conversation Guide. And I know Sam probably has it somewhere, but but I'll make sure that gets into your hands, because that really makes it. And it doesn't tell you how to do it. It just shows the questions. It's like a framework, a little skeletal, scripty sort of thing for chronic stuff and for acute stuff.
Right.
So,
Yeah,
yeah.
I think that would probably be really helpful for someone going into either emergency or new, just maybe new to those types of conversations, or
Mm,
even someone experienced. Sometimes it's nice to have something to fall back on.
absolutely. Because we're right there in the middle of it with them too, and our emotions are not to be discounted either, if it's to be a partnership.
For sure. Are there any other questions? I know we're probably about 5 minutes past the hour.
Okay, thank you, Sierra, for that. I would suggest, so yeah, vet meds advise clients about working their other pets through the grief of loss of the pets. Preemptive action. Yeah, preemptive is always super, super tricky, because, grief can be a little like, kind of like a burn injury, where the tissue is going to take a while to declare itself, and it's going to just progress before it gets better, and it's going to progress like this, kind of all over the place. So working their other pets through the grief really starts with what we saw in the video, is just observing them and including them. A little bit like the children. So think about, like, because I've had lots of little kids in euthanasia appointments and stuff, usually in the home. And I always say to the parents, like, they are allowed to come and go as they please. I'll tell them, what we're doing. I don't use euphemisms or anything like that, but in some parallel way with the other pets, allowing them to express the behavior that they need to. So that could very well be going to the window 40 times a day for the first week, and then 30 times a day for the second week. And, just seeing what that is, because they have to rehearse, they have to educate that panic circuit. So it doesn't necessarily mean they're like devastated and in emotional pain in the same way we think of it, but that same circuit in the limbic system still needs to kind of resolve itself. So allowing them whatever behavior they need to do is probably the critical thing. And then watching for if they start to become withdrawn, if they stop interacting, if they want to just hole up, if they stop eating, if they stop really, if their bathroom habits change, if if you see immune stuff start to happen, they start catching little things here and there, that's a sign of the body in a chronically stressed out state. Because it's the sympathetic tone is just on and then left on. And in animals, when it's left on, you really see it. In humans, I mean, we go through most of our days with our sympathetic nervous system stuck in the on position, and that's why we can't sleep, and that's why we go see therapists, and that's why we have, the whole mental health industry. But for the I guess the preemptive action is include them as best you can. Let them lay down with the animal, whether, either before or after the death. Allow them to sniff, allow them to touch, allow them to do just what you saw my horses doing, and give them the chance to have some sort of outlet, and then notice, if it's starting to get too much, if you're starting to see all that stuff go away that's indicative of chronic stress.
Kind of piggybacking off of Sierra's question, do you recommend that people, like for euthanasias that happen in the hospital or in the clinic, that people take those animals home for the other animals to?
Mm.
to be with? Because people ask me that all the time, and I tell them, like, you can take
Mhm.
the body with you, but I never know if it's something that I should like truly be recommending.
Yeah, it's always, and this is the wonderful thing about going into social work and working with, human clients and things like that. I mean, the best way is just ask the client what their preference is. It's like, do you have any preferences on, like, then that's the other thing we talk about from the time of diagnosis or the time of presentation in an ER is, yes, we have to get to a euthanasia decision, but also that is the time to discuss aftercare as early as possible. And aftercare can be, okay, do you have any questions about your other animals? If they need anything, is there a way we can help you, arrange kind of a wake or a viewing or stuff, to use, you know, words that are easily anthropomorphic, but I don't think they are. Uh,
Yeah.
but yeah, absolutely. It's just asking asking them preferences, find out, empower them to tell you what their wishes are, and that answers it for you, hopefully.
Okay. No, thank you. Yeah. Yeah. I always leave it up to the client. I mean, I would never tell someone, no, you can't take, the body back with you. We just try to tell them, like, educate them on some of the things that you might see. And, after
Mhm,
6 or so hours, you want to make sure that you can put it in the freezer or something like that,
mhm.
preserve it somehow. So yeah.
And making that stuff mentionable is just, that's a relief, isn't it?
Yeah. Yeah.
Cool.
Awesome. Well, we will, I could sit here and ask questions all day. I'm not going to do that. I know that Dave has to get on with his night, but, thank you all for coming. Dave, thank you for such an amazing presentation. Again,
Pleasure.
like everyone has mentioned, in veterinary school, at least, it's not something that we talk about a lot. But it's something that we could be hit with in that first week
Mm.
of, being out of school. And so it's really important that we have these conversations. Um, if you are looking for CE credit, please make sure that you shoot over your email address. I have most email addresses from people that signed up, but if you don't have your first and last name there, it's just hard for me to match it up. And this recording will be available on Workplace. If you are not a member of Black DVM Network and you would like it, just shoot us an email. We're happy to send it over. But with that, thank you all for coming. If you have questions, like we'll be hanging out, but other than that, we'll see you next time. Everyone's saying thank you in the chat. That's awesome. And David, if you have an email address that you would like for me to use, just shoot it over. That's the only one that I don't have. Let me stop the recording at least.